I
I
said,
told him,
Mom doesn't spend that kind of money on you for
Step down.
birthdays. Well, you know,
have
done
to
her.
Yeah, right.
Code,
Mom
your
doesn't
code,
spoil
right
things.
before we got
and work in the cath lab at Columbus. So when you come to the cath lab, you might see me. Some things today we're going to talk about. First thing I'm going to do, the first lesson we're going to go over is an LZ course, and then later on I have a fluid resuscitation, blood resuscitation, and airway presentation that I'd like to go over. Whenever we were talking to Tammy about what all she wanted us to do, that's kind of what we came up with. So that's what we'll go with. So our objectives today are to go over safety, LZ selection coordination, LZ operations, and things that can go wrong that hopefully won't go wrong. So I work for PHI. PHI pays my paycheck, but we are affiliated with St. Vincent. So whenever you see St. Vincent, that's us, but our mother company is PHI. And that's who onboarded me, and safety is a big part of their culture there. We have a Destination Zero motto, and that just means that we are hoping to have 0 accidents, 0 issues with our operations. Whenever you are picking an LZ, things that we want to know about ahead of time, whenever you're on the phone with, or if our dispatchers are on the phone, one big thing that we need to know about is any hazmat that you might know of that's in the area. Patients have to be decontaminated completely before we can put them in the aircraft, because you take an ambulance and you cut it in half, that's about the amount of room that we have back there. So anything that the patient has on them or about them, we're also going to be getting on us as well. We also need to be parked uphill, upwind of any hazmat issues that you guys come in contact with. Whenever you're selecting an LZ, we require 100 by 100, but we prefer anything bigger than that. That would be even better. We like flat surfaces or less than 5 degrees. We can do 5 degrees, but it's whenever you start parking on a slope, that messes with unloading and loading patients again in the rotor position as well. Just be sure that whatever you choose also is clear of any overhead obstructions. Make sure that there's no big trees or towers. We have helicopters supposed to be coming in today, and the first thing I did was send them a picture of the LZ, show them where I want them to park, and then I circled the giant tower that's on the northeast side of this building, and I said, there's a big tower here, be aware of it. Also need to be aware of anything that is loose on the ground or in the area that can be a projectile whenever we do come in for a landing, because it can puncture your cars, it can puncture the aircraft, and if the aircraft gets hit with anything, that aircraft is out of service until a mechanic can come and check it out and put it back in service. So we need to make sure that we are not getting hit. Surface selection, we prefer like a parking lot, paved area. We will park in gravel areas, but those rocks do become projectiles. And we can also do grass as long as it's packed down. Joe and I walked out to this area this morning and just kind of made sure that it wasn't going to be too soft. If it's too soft and our skids start to sink, we have to lift and find another place to land. Yeah. I'll go over the brownout conditions here in a minute. There's a video that's connected to this, so we can talk about that. This gets a little repetitive, so I do apologize, but obstructions to think about would be the wires, trees and poles, bushes and stumps, rocks, buildings, fences. Fences are a big issue. Actually, one of our Kentucky aircrafts just hit a fence this last year, and it was a big deal. So keep those in mind as well. Road signs, animals. So in a county, not this county, but a county close by here, we had a patient that was mauled by a bull, and the fire department wanted to land us in the same field that the bull was still in. So we had to tell them, hey, you need to find somewhere else, or you need to remove the bull because we're not landing there. Be aware of people, because you know how people are. They all want to have a picture of or video of whatever's happening, and they will put themselves in danger and not even realize that. Vehicles are a big issue because people also don't like to be stuck in traffic, and so they like to try and race through or try and go around an LZ and put themselves in danger and us in danger and you in danger. And more recently, we've been having more issues with drones. Drones have been kind of a big topic of discussion. Yep. We like to coordinate because we know that drones are important. So if we are coming to do something with you guys and there are drones being used for search and rescue or what have you, just let us know ahead of time. Just the drones will have to be grounded before we can come in below 1,500 feet. And that's just land them, tell us that they're landed, and then we'll come in for landing as well. So just follow your own guidelines whenever it comes to using your personal apparatuses and emergency vehicles. They're useful for us because they're big and we can see them from the sky. We can see strobes and we can see cones as long as they're laid on their side, but it's hard to see much else from up high. But the fire trucks and police cars, we can see those really well. You can use those to block traffic. You can use those to mark lines. Those are great pieces of equipment that can be used for more than one thing. This just goes over things that we prefer as far as marking our LZs, the cones. If you have a cone, lay it on its side. We don't like flares, and we're not really keen on super bright lights like the LED lights. Blue lights we can't see under night vision goggles. So if you have anything other than a blue light at nighttime, that would be best. If you don't have anything and you have to use like your car lights, that's fine. Just make yourself pointed towards where you're wanting us to land. And just whenever we're coming into land, whenever we're on final, we will let you know that we're on final. Keep your lights on until we're about 500 feet and then turn your lights off because we'll be on NVGs at that point. This is just a normal way that we like to come in. We don't like to come in and come straight down. We like to come in at an angle. That's a pilot question. I don't exactly know why they like it that way, but that's how most of them.
Takes a lot more power to hover down.
Yeah, and they're just not used to it. There's also, it puts us at risk for yaw, I know that, which is where if a wind, if it comes in and swipes, our tail can swipe and it puts us out of control. So we park into the wind. So our LZ coordinator needs to be outside of the 100 by 100 area, facing whatever the direction is that we're coming in for a landing, so against the wind. This goes over drones again. Looks like we've had a drone strike. This must have been somewhere down in Texas. I don't recognize that aircraft or that pilot, but.
Are you seeing more and more drones?
We are, especially whenever it comes to like rescue type things, but also just like recreation drones, people taking photos and.
Because I know the police departments and stuff use and have, you know, but I've noticed a lot of people are starting to get their own and they're everywhere.
So the good thing about like the police and fire drones, most of those that I have seen being used in that capacity are marked with a green light on top, so that it makes them easier to see.
Okay.
But like the recreational drones, the big drones that people are using to take pictures of things, you can't see those. They look like birds. Like you can't. They're tiny. So. This is just one picture of what a drone can do.
Oh my.
Yeah. Imagine what it can do to a little baby pop can helicopter. Let me pause this for a second so I can tell you what's going on. So there are two situations that we like to warn people about. We don't have it very often here. It's more in like desert regions or whenever there's a lot of snow outside that's loose, brownout and whiteout conditions. If we come in for a landing and we see that this start to happen, usually we will see it start from the back and work its way forward. We cannot land if we cannot see the ground. So we'll have to raise up and go around. One thing that you guys can do to prevent that, or if we're coming in and we're like brownout conditions, you're gonna have to do something about it, wet it down. Usually that's snow and dirt. That'll help take care of that problem. Yeah. Yep. He said, no, thank you. Other LZ considerations, we've already talked about people or animals. Do you have enough people to help? There's 2 of us that are able to help, usually only in the back, and then whatever other people that you have on scene. Think about, especially if we are having to land in fields, it's hard to get people to aircrafts on stretchers. So the more people, the better. Make sure that you have eye and ear protection if you have it. We allow fire helmets to come into LZs, but like ball caps, we have to leave those behind. Just some general things that we like to hear whenever we're getting an LZ report. We like a general description, make sure you know how big it is. Any hazards that you can see. So we'll go outside and I'll kind of show you what I like to do whenever I'm telling people how to pick LZs and what to show you. But I like to just point straight at it, away from my face, and make a circle. And anything that my finger touches is something that the aircraft needs to know about. And wind direction, if you're able to know the wind direction, that's super helpful as well. Any hazmat issues. If you have any other aircrafts coming in, that's a big thing that we need to know. If our comms knows earlier, that would be even better. And then any other patient information that you're able to obtain. The LZ coordinator or command is who is usually in charge of giving these LZ reports, and that's who we talk to. This is an example of what we like to hear. So the aircraft says, yeah, this is what they like to hear. Your LZ will be about 1,000 feet due west of the accident scene. The LZ is about 200 by 100 grass surface. There's a 30-foot power lines located on the east side of the LZ, 75-foot tree lines on the north and east side. And we marked your LZ with cones per the medic unit, your patients. This patient, and she's this big, and this happened to her. Don't really know what's going on. There's a flagpole as well, and strong winds. And then we will do a high recon and a low recon before we will come in to land. So if you see us doing giant circles, it doesn't mean that we've passed your LZ completely. We are just making sure that we are getting a good high view and then a lower view before we come in for landing. We will stay on whatever frequency we start on until we are on the ground. That's just for everybody's safety, so that in case something were to change or we need to switch places, then you can get back with us really quickly. So I think that that's an Arizona channel that they have listed on here. KMA4 is the local channel here. This is what we usually use whenever we come to Bartholomew County. If you do have multiple aircrafts coming in, we require a minimum of 50 feet between us, but we prefer more if possible. We don't have any helicopters like this, but our helicopters are probably the next lowest as far as the rotors being low. The most dangerous part of our helicopter, which is a 407, is the front. if you're looking from the front, it's the front right-hand corner. That's the most dangerous part. It's the lowest part. That's just how it's angled. I don't remember exactly how high it is, but does anybody know Doug Payne on Southern Brown Department? He can touch it just by doing this. So Leroy might be able to touch it. Like, you don't have to be super tall. You can probably reach it whenever it's still. Never approach from the front. Always make eye contact. If you do have to go into the LZ to talk to the pilot for whatever reason, make eye contact and get a thumbs up before you do come in, and then you need to approach from either 9 o'clock or 3 o'clock. And stay away from the tail rotor. The tail rotor, here we go, it's one of the most dangerous parts. It is the most dangerous part of our aircraft because it's exposed. And it spins about 3,000 times a minute. So it is invisible at night. You cannot see it. Even during the day, I think it's pretty invisible. But it will take one time, and then there will be no more times to get hit by that. So whoever is in charge of the LZ coordinator or scene command, that person is in charge of also making sure that nobody is doing anything stupid and running towards the tail rotor. This just goes over loading. We like to use the stretcher when possible, just because I think that it's just helpful. I like wheels, but we can also do the sled, especially if we're in a field where you just carry the patient at least 4 corners, more if possible, more people if possible. We'll go in at the 9 o'clock area to load the patient. Our aircraft is a feet first load, and we can take patients safely up to 400 pounds. That is what our weight rating is. But it also kind of, we can take up to 400 pounds, but it has to probably be a tall 400 pounder. Whenever you start getting shorter and wider, that's whenever it becomes an issue of the patient actually fitting into our space. Whenever the aircraft gets here, hopefully they're coming soon. They haven't told me that they've left yet. Oh, wait. They've lifted. What was I saying? Yes, they're coming. If the patient can fit in the tunnel, we'll let you look at the tunnel to see how big it is. We've taken some pretty big people though. Like, if it fits, it ships. And whenever I say that, I'm being very serious. Like, we've taken some stout folks before. So
there's not really a weight limit per se?
Just the 400 pounds. And if we can lift up on it, we can probably take bigger. It just has to, their fluff has to be compressible. Does that make sense? We can take a tappy. Yeah, we can. Especially if it's not an airway issue. If the patient's able to maintain their own airway, even the bigger folks, like we've taken a 400 pounder before. We just both had to sit on the left side of the aircraft, or the right side of the aircraft. And then we pull him back, yeah.
What about height? Is somebody's height?
No, not usually. I'll just lay them down. If they're really tall guys, I'll just lay them down and let their head kind of hang off. We've got towels and, yeah.
No. I didn't know if there was a Steve Johnson or an Andrew Fields.
Nope.
Sorry, Steve, I had to.
I can fit anywhere.
This is on, right? Okay. Yeah. Okay, always use ear and eye protection whenever you have it. Fire helmets are good, hats are bad. Watch for visual signals from the flight crew. We try to do all of our briefing before we go near the helicopter, because whenever you get under the rotors, it's really loud and it's hard to hear. Whoever is at the front right foot of the patient will be the one who is in charge of announcing the lifting of the patient once we get in there. Things to keep in mind whenever we are doing hot loading situations, if they are especially on a stretcher, we want to make sure that if they are on a sheet, that whenever we lift that patient, somebody has a hold of that sheet so that it doesn't get sucked up into the rotor. That will ground us. Yep. We'll make sure that everybody is clear prior to our takeoff. So if you see me looking out the window, it's not because I'm just enjoying the view, it's because I'm making sure that everybody's clear from my side of the aircraft. I do wave whenever I leave, but that's just because I like you guys. Make sure that we're reporting to other aircrafts that we're leaving. We will also do that, but report to your dispatcher that, hey, Stat Flight 2 is lifting with 1, this aircraft is still on the ground. And then just maintain radio contact KMA4 with us until we are out of your area. This goes over as far like our NVGs. We've talked briefly about them. We cannot see blue lights under NVGs, and everything else is also very hard to see. And that is also dependent on how luminescent the moon is that night. We kind of rely on how much light the moon gives off. It will attract light from like houses and buildings, but it's not enough. We need the moon. On really dark nights, even with NVGs, it is very hard to see obstructions. If things go wrong, I will put this in the universe, I want to be saved. So if you guys are responding to an issue, just know that I want to be saved. Make sure that the rotor blades have stopped. Do not approach the aircraft if the rotor blades have not stopped. You only approach under the direction of the flight crew if we're, awake and able to tell you that. If we're not awake or if you don't see us, just wait until the rotors stop before you approach the aircraft. We use jet fuel, which is flammable, and foam is the best thing to use on that. Our windows are plastic and they're able to be popped out pretty easily. So if you need to get access, just pop that window out. That's very interesting. Yep, the intakes, that's where they want you to point your foam at to put out fires. So the top rotor spins about 400 times a minute, the tail rotor 2,000 to 3,000 times a minute, so they are very fast and they will cause damage, so just wait until it's stopped. We do have a brake. If the pilot is not incapacitated, they'll brake it, but that's not guaranteed. So general aircraft knowledge, we want you to know it's made mainly of aluminum and titanium. It's a honeycomb structure, so it's fragile, but it also means that it works better for you because you can break it a little bit easier if you need to. We use Jet A fuel. This is what I was talking about, our plastic windows. They're designed to pop out from the inside or the outside, so whichever area you need to make access to, just pop it out. Be safe out there. I think that we did this like perfect timing. Maybe. I thought I heard them. So we'll make our way outside. They should be not too far out. We have Jakayla and Chris, and what's your name? I'm so sorry. Jordan here today, and then Haley as well, and Noah. He's our base mascot. Yeah. So the second presentation I have, whenever I was talking to Tammy, she said that she just needed something medical. So we decided as a base to talk about airway, blood, and fluid management for first responders. Great picture, PS, right? Me and ChatGPT made that. So our objectives is to be able to recognize shock states, select appropriate fluid strategies, understand blood administration. Are you guys still getting blood here? Is that still a thing? How soon do you think you're?
I think we're just in the process of the transition between how we're going to obtain it, get the contract between
Oh, cool.
our current hospital as far as the blood bank goes.
Mm-hmm.
So that,
Will it be whole blood? Do you know?
I don't know.
Okay.
I know the
My
aspects.
understanding is that it was.
Yeah, I'm not quite sure
Nice.
yet.
Cool. Very good. Very good. Super helpful. It would be great for the community for sure. And then identify airway priorities and modify any treatments for pediatric patients or other special populations that you can think of, that I thought of. So whenever I was starting to look up things for this PowerPoint, I came across this resuscitation triangle thing, and it talks about airway and oxygen delivery. Blood is what carries the oxygen to the tissues, and circulation is what moves the blood around. So no amount of fluid is going to fix a hemorrhage, and no amount of blood is going to fix a bad airway. Stuff to think about. We'll talk about shock here. Signs and symptoms for adults: altered mental status, weak radial pulse, low systolic pressure, narrow pulse pressures, tachycardia, and then skin condition, things that you can see from far away. You can usually tell when somebody, an adult anyways, is on their way into shock if they're not already in shock. Kids are a little bit different. They're a little bit harder to recognize because they compensate so well. So early signs for them: they'll start breathing faster, their heart rates will increase, and then their skin may look a little bit like it has a little bit of pallor, but that may not be until later on for them as well. It just depends on the kid. If you have your cards, do you guys have little pediatric cards or like anything to reference as far as like what normal heart rates are for different age groups? Yeah, just keep those in mind. If it's higher than that, then you may be working towards a shock state for a kid. If a kid ends up in hypotensive, that's bad. That's bad for them. Arrest is imminent if a kid is hypotensive. Different types of shock. We got the hypovolemic, which is also hemorrhagic. So think of bleeding or post like diarrhea, vomiting type thing, that type of thing. Cardiogenic, STEMI CHF, distributive sepsis or anaphylaxis, and obstructive tension pneumothorax, embolisms, that type of thing. So we are evolving our treatments. The old way that we would consider approaching these types of patients is airway, breathing, circulation, 2 large bore IVs, and titrate to effect with saline. We're trying to get away from that and treat patients a little bit in a more controlled way. So we think circulation first, because if somebody is bleeding and they have no blood left, then an airway is not important at all at that point. So we need to control bleeding first. And I'm talking like massive bleeding. If they just have like a scrape on their arm, obviously take care of the airway first, but you get it. Use blood if it's suspected that it is a bleeding situation. Use blood first, and we want to avoid dilutional coagulopathy, and we also want to avoid fluid overload in patients. Anytime you want to come up here, it's fine. Okay. So as far as fluid resuscitation though, because fluids are still good, we still need to think about some sort of fluid resuscitation for people as well. It's just to maintain perfusion though. So it's not fixing the problem. It's just maintaining as much as we can. The current trend is like smaller boluses. So we'll do a 250 challenge. We'll do a 500 challenge. Our targets are systolic of 90, which is, you know, awesome, but really we look at maps more, and our maps of 70 are closer to what we consider the goal. And if you have a radial pulse, that's awesome too. Common types that you guys might use be normal saline, lactated ringers, and plasma light. They're easily available, they're not expensive, but they don't carry oxygen, and they can make things worse with acidosis. Lactated ringers is a little less acidic than normal saline, so that's just something to keep in mind as well for patients that you think might have higher levels of acidosis. As far as sepsis is concerned, that is one of the big things where we want to have a lot of fluid put into them. Our target goal is 30 mils per kilogram. We like to figure out pretty early, so your little ladies that are in a nursing home and you walk in and get hit immediately with a stench of like urine, like gross urine, you know exactly what I'm talking about. Or somebody who's been really sick for more than a week with like a cold, they might be working towards sepsis. Those are people that are going to be primed for the 30 mils per kilogram fluid resuscitation. Special populations you need to be a little bit careful with and maybe do smaller boluses at a time just to make sure that you are not causing worse problems are the CHF patients and dialysis patients. There's different levels of burn resuscitation with fluids as well. So you want to do this one?
So when you have a burn, you have the skin, your outer barrier is broken. And so then you get all this leakage. And then with the swelling, you get even more leakage out. So you're losing tons and tons of fluid, not just by thermal loss, but by fluid loss as well. And then it causes your capillaries to leak into those tissues, which makes you swell even more. So you can get hypovolemic really quickly with those patients, even though you're not seeing any kind of like frank blood loss. And then shock occurs really quickly. So first, you want to stop the burning process. Clothes are typically made out of some sort of synthetic material, and so they just turn into melted plastic whenever they get burned. So you want to get all those off because those keep heat for a long, long time. And then jewelry especially as well, so necklaces, and then any rings on their fingers, because your hands are the first thing to swell up initially. Even if the hands aren't burned, you're giving those patients fluid and their hands are going to swell. So that can create some really bad complications down the road if those things aren't removed. And if you have rafter shears, those are the best things to cut rings off with. They're really, really easy. Making sure that you're assessing their airway early, especially if they have like inhalation burns, even if it's just like a flashover to where they just like breathed in some superheated air, that's going to continue to swell, and that could be a really big problem for you before you even get to the hospital. So sometimes with those patients, you have to make that decision, even though they're sitting there, you know, sitting up, vital signs are totally normal on room air and talking to you. That may not be the case in 30 minutes. That tissue in the airway is going to start to swell and then create a really big problem. And we really don't want to cut anybody's neck. That's a bad day. And then thinking about anything that got burned is going to swell, and then the fluids that you're giving that patient to resuscitate them is going to make them swell even more. So that's going to create an even bigger problem if they're over fluid resuscitated also. And then establishing your IV access for burns, and especially for pain control. Like, pain control is a huge thing for these patients. If you don't have any options for access except for burn sites, then put it on burned skin. Like, any access is better than no access with these patients to get them fluids and control and stuff. And then preventing hypothermia, so these patients don't have any skin to keep them warm. And they get cold really, really quickly. And I mean, typically I feel like whenever burn patients are brought in, typically their body temperatures are like 5 or 6 degrees lower than what they should be. And so that's a really, really huge thing with these patients, because the lower your temperature is, it makes everything worse. Medicines don't work as well. You don't clot, all kinds of things.
With your pain medications too, try not to give them IM. You've got damage to the skin and they can't absorb correctly. So if you have to drill your awake patient, do it. Drill them, give them an MS, IV, or IO before anything else if you're able to.
And then reminder for, especially in this area, like we don't have burn centers even remotely close to this area. So if you've got adults greater than 20%, TDSA, they absolutely 100%, you're gonna have to take that long drive to a burn center. And then kids
Or a
are even
helicopter.
less than that, so 10 to 15%. And that doesn't include those special areas. So if you have circumferential burns anywhere, if you have burns to the hands, to the face, to the genitals, anything like that, that you think is gonna need plastic surgery intervention, they need to go to a burn center. Like, just getting them wound care at a hospital that doesn't have burn experience is not an option. Like, they absolutely are gonna be transferred anyway. They need to get there as soon as possible.
Who can tell me where the burn centers are close by? Eskenazi. Guess where else? St. Vincent's, and we treat kids and adults in our burn centers. Just saying. So you.
20 to 30 minutes
It
away.
is, but
But
if you think
it's 3
about
minutes
it,
of flight.
if you have a family that gets burned, then you're able to take them to the same facility. You're able to keep them together.
Yep.
So that does make a big difference in the grand scheme of things. If you have, parent and kid that are burned together, then it's going to make it significantly better for them in the long run.
Does Louisville area have a burn center?
They do, yep. So U of L is the adult burn center down there, and then Norton Children's is the kids burn center.
In Richmond, Reed Hospital, I had a burn patient go there for some reason.
Maybe that was the only available
It was a few years ago, but that's, yeah.
bed.
All right.
Yeah.
So which
Eskenazi is full, yeah.
which type of burn do you guys think requires the most fluid words are hard. Resuscitation. Do you think it's like fire burns, chemical burns, electrical burns? Which one? Just throw something out. You think it's the
Liquids.
electrical? Yep, it's a big deal. Those lightning strike patients, they do happen. So this is just the rule of nines. Y'all probably remember that from whenever you first took your medic courses. You probably had that down to a science. Flames are scalds, and they're changing that as well. You can still do your Parkland formula, but it's not as much as what you would think anymore. So it's kids and adults that are greater than 14 for flames. It's 2 mils per kilogram times the body surface area. And kids are 3. And they prefer that you use something that contains a little bit of sugar, because kids and infants burn sugar a lot faster than adults do. But you do need to keep in mind to check a blood sugar for adult patients as well, because they also still burn sugar. Electrical burns require up to 4 mils per kilogram times the body surface area, and you are really watching their urine output. I know that you guys won't see the urine output per se, but if you notice that they've urinated at all, that's something that you need to think about telling whenever you drop them off, because they are keeping track of that. They have to make sure that they are producing up to what, like
0.5 per kilo.
0.5,
Like them to be 30 to 60
30 to 60 per hour.
per hour.
Yeah, mils.
Kiddos are 1 per kilo.
So super important.
And if you guys get on a scene and you're like, shit, this patient is burnt really bad, just start a 500 bolus and get to where you need to go.
And they can calculate the rest of it later. Mhm.
Because those burns are going to evolve over time too. So even things that you see and you're like, oh, it's probably a first, second degree, a really bad injury, they're going to get worse after swelling and everything, and they have time to blister. So the calculation changes all the time. So what you send out as a 25% burn may end up being a 38% burn by the time they get to the burn center. So just don't focus too much on trying to actually calculate what the percentage is. Just start your 500 for adults, 250 for kids, and call it a day.
Yep.
And thinking about that with adults, like I know that we're sometimes concerned about fluid overload. With kids, unless they have like some really bad congenital defects, like they got really good working kidneys. So the chances of really fluid overloading a kid, I mean, I'm not saying to give a kid this size, a liter, because that would be no way.
Silly.
But we're not gonna be as concerned with kids and fluids, you know, just a rough guesstimate like Jaquila was saying. Like a 250 bolus will do somebody really good. And then right around 500 for most body weights for the initial bolus for a burn is really, really sufficient. I mean, we're not loading in 3 liters to a patient like we thought we were before.
All right.
And then what's the fluid that we're going to give burn the patient? LR. What's the fluid that we give with blood? What do we have to give with blood?
Saline.
Same,
Yep, it's closer to the pH.
Yep, can't give. Although, when you bring in a patient, the trauma surgeons will want to switch them immediately to give them LR. But in our case, when we're transporting and we're usually piggybacking, so we've got one side spiked with saline and then one side spiked with blood, we're gonna always want to start saline on those patients that we think that we're gonna give blood to.
And then talking about late signs, so she's got hypotension up here. So if we're seeing hypotension in a burn patient, they've been burnt for like a few hours. This isn't something immediate. So if you have a burn patient that you know this just happened to and they're hypotensive, they're going to be tachycardic, right? They're in pain, they've got all this stuff going on. But if they're hypotensive already, they've got other trauma going on, and we need to look for that. Did they get burnt and they jumped out of a second-story window to get out of the house, right? They probably got some other internal injuries, so don't get distracted by the burn.
As far as treating kids, early signs, we've talked about it, tachycardia, a little bit delayed cap refill, poor skin perfusion, but whenever you get to the hypotension in kids, that's a late sign. You are behind the 8 ball at that point. Boluses for kids, for pediatric kids are 20 mils per kilogram. For neonates, it's 10 milligrams per kilogram. I think that our protocol is 2 or 3 boluses before we have to call again.
Up to 60 per kilo.
Yeah.
Per fluid.
Yep. Just reassess after every bolus. Look for signs of improvement. If you get signs of improvement, slow your fluids back down. And then prioritize blood when appropriate. Bridges for things. You guys leaving? Okay. Bye, guys. Thank you for coming.
Thank you.
So push dose pressors we use as a bridge to either a infusion, a pressor infusion, or whatever else they need, whatever other intervention they're needing. But it's not to be used as the only treatment. Like it just needs to be used, and then you need to find a longer term intervention. So it temporarily helps boost support of blood pressure, helps boost support to get blood, any sort of like post-intubation hypotension or peri-arrest hypotension, or if you walk in the door and they've got a blood pressure of 70 over 20 and you're trying to get things going and you need to start an infusion, like give them a little push dose presser. We use epi and phenol as our push dose pressers. It's 20 mics for adults, or 200 mics of phenol for adults for our push doses. And yeah, you can make those. The phenol has to be put into a 100 bag to make your push dose presser. Epi, you can use cardiac epi and do 1 mil of cardiac epi into 9 mils of saline, so a flush, and that's push dose epi. So risks, you can give too much. You can give too much, and it can cause more issues if you've got the wrong concentration. If it's not a good IV and you're putting pressors into a bad IV, that's not good either. It can cause your heart rate to raise, which is why I also mentioned phenol. Phenol affects the heart rate less than epi. So if you've got a patient who has a heart rate of 130 already, think about maybe using phenol as your push dose presser instead of epi. And it requires training.
Really quick on traumatic shock, you said use caution with that. The only pressor that we do have is
Epi.
Epi.
Oh.
So, no.
Yeah, I would rather have the heart rate jump a little bit than to have them.
And especially
Poop
with
out.
kids. Kids always
Yes.
have high heart rates. Just-
Yes.
I mean, you would hope they'd have higher heart rates. But even if their heart rate is 150, the first line pressor for them is always still epi.
Yep. So
Or
kiddos are first line. Yeah. Kiddos are epi first line. As far as our protocols go, first line for adult presser, like long-term presser, is norepi. We carry vasopressin. That's like our second line. So if we get up to 20 per kilo of norepi, we start vasopressin. And then after that, for the longer term, we use epi or phenol, just based on the patient. So moving away from fluid resuscitation and bridging the gaps, the main thing that's going to fix your trauma patients is blood. They need blood. So your goal initially is to stop the bleeding. So wherever the bleeding is happening, that needs to be stopped, whether that's with a direct pressure or a tourniquet or wound packing. Wound packing is something that I had to get used to. I had never really done it until I started this job, and now I feel like I do it all the time. So don't be afraid to stick your dirty gloves in somebody's hole and get that wound packed. I mean, I'm not, I know it sounds weird to say it that way, but you gotta stop the bleeding one way or another.
We somebody up from a hospital, like a small hospital, where the doctor had packed the wound and then sutured over the top of it just so we could get this patient to a different hospital to be able to get them, because the vasculature was all damaged, so.
I had a patient out of Lawrence County not too long ago who had his entire maxilla was separated from the rest of his skull. So he was bleeding in his skull, in his mouth. It was everywhere. I literally took combat gauze and shoved it in this guy's mouth and just kept shoving it. It didn't fix it completely, but it slowed it down a little bit. So you got to do what you got to do to get the bleeding to stop. That is the main thing that they need, and that helps to slow this new concept. You guys are all familiar with the trauma triad of death. They have changed it to a diamond, diamond of death. Lethal diamond is what they call it. So it still has the hypothermia causing the coagulopathy, but they have added hypocalcemia to that. So anytime you lose blood, you lose calcium. And anytime you use transfusions, you also, there are things in the blood that help keep it uncoagulated that will also make you lose calcium. So after 2 transfusions of blood, you need to be thinking about adding calcium to their treatment. And then acidosis as well.
How much calcium?
So for an adult, 1 of calcium chloride. You guys don't carry gluconate, right? Calcium gluconate. Yeah.
Yeah,
So
it's
just
an amp of
1 calcium
every
chloride.
2 units.
Yep. So what do you think kills trauma patients faster? Blood loss or us trying to fill their tank with fluids?
Blood loss.
Us. Oversaturate.
I think that it's honestly probably about equal. Like the more you try and fill their tank with fluids, you're turning their blood to Kool-Aid, you're making them way more acidic. They're not going to survive it either. So, yep, the faster you can stop the bleeding and add more blood, the better your outcomes are going to be.
And when you're filling their tank with fluids, if you don't have blood, because they need, they've lost a ton of blood, when you're filling their tank with fluids, you're making their vessels way bigger. And so that is going to, when you need to clot, you want your vessels to clamp down. And so that makes them less likely to vasoconstrict to be able to clamp down and push all that blood needed to go to their vital organs instead of out to their peripheral. And then once they get to the hospital, they've got a really full tank of pink lemonade, and so it is almost impossible at that point to put blood into a full tank already to replace that pink lemonade. So
Do you guys have presser protocols here? Yeah.
is it just push dose, or can you do dirty epi drip? Oh, sweet.
Good.
So if you don't
Better
have
than
blood,
nothing.
and you have a patient that's profoundly hypotensive, and you've already given them a liter of fluid, then you probably need to be spiking your dirty epi.
Yep.
Because that's going to be better for them in the long run, versus just pushing more fluid into them.
So, why blood? Why blood? Somebody tell me why blood. What does blood do that fluid can't? Mm-hmm. What else is blood good for? Clotting. That's a big one. Mm-hmm. Mm-hmm. So it's really good for traumatic hemorrhage, obviously, that's pretty self-evident. But if you suspect any sort of internal bleeding, like if you've got a patient who maybe doesn't have any external signs of bleeding, but they've been in a wreck and weren't wearing a seatbelt and went over their handlebars or something, that can cause a pelvic fracture, that can cause internal bleeding in GI patients. A lot of times you're going to see that, but you can die from a GI bleed just as fast as you can die from a traumatic bleed. So think about your blood if you get these types of patients. If you do decide to do component blood therapy instead of whole blood therapy, studies have shown that it's better if you can stack them 1:1:1 ratio of packed cells, plasma, and platelets. It just mimics whole blood, and yeah. So, as far as clotting factors, does anybody know which component carries the clotting factors? That's what I would have thought too.
Plasma.
It's plasma.
Yeah. Plasma,
So, yep, recent
platelets, and whole blood.
yeah.
Red blood cells packed red blood cells do not have clotting factors in them. And that's typically what a hospital will give you when they say, here, transfer this patient, they're bleeding out, they really need to get to that trauma center real quick. And your red blood cells are gonna do a whole lot of nothing for helping clot that patient. So, making sure that you're asking for either plasma or platelets, which they sometimes call plasma FFP as well. Asking for those additional components is going to be really important.
Mm-hmm. Mm-hmm. Does anybody know what Hand-Heavy is? Have you guys heard of Hand-Heavy or Dr. Hand-Heavy? He recently did a podcast where he's looking at trialing putting plasma on their EMS units instead of whole blood.
That makes more sense to me.
Yeah. So, interesting. So pediatrics, everybody gets a little nervous whenever it comes to treating peds. I am guilty of it as well. But some errors that are common whenever you treat pediatric patients, especially with blood, is waiting too long, not warming the blood, giving too much fluid, or not calculating accurately. Whole blood, for us, we give 10 mils per kilogram of blood, and we do the push-pull method. So we'll pull it out with, oh my goodness.
A 60 cc syringe.
Thank you. And we'll push it. That way we're giving the exact amount. So a key point to think about, a 15-kilo kid only has about 1,200 mils of blood in their body. So even a little bit of blood loss is going to affect them pretty profoundly.
Is there a maximum amount of blood that you can give? I mean, anybody, kid, adult, anybody? Is there like a max? Is there a number? No. If they're bleeding, if they're still bleeding out, then they need more blood. And sometimes you can't get the blood in as fast as what they're bleeding it out. So, just realizing that when you're reassessing them, or even if you're like, man, they definitely have some big trauma in their belly and they have a whole belly full of blood. If they're still hypotensive and you're like, this blood should have really worked, give them more blood. Like, if they're still bleeding and they still look like crap, then they need more blood.
They can fix RH factor patients later on. Like, that's not going to be something that you will have to deal with immediately. That's something that they can fix later on. One thing with blood transfusions, though, to keep an eye on, there are times whenever they will have what's kind of like an anaphylactic reaction to the blood. If it's in a trauma situation, life over limb kind of thing, but like give more epi. So yeah, but if it's just like a packed cells, GI bleed type thing, and you're keeping an eye on whether they're having reactions to that blood, then you might need to turn that off and treat with pressors until they can figure out what happened. TXA, that's a medication that's kind of become popular over the last little bit. They had some trials where they had 20,000 trauma patients, and it was proven to reduce death from bleeding. As the greatest benefit is whenever you can give it within an hour. After 3 hours, it's not going to work very good. But here's this little video I found.
While Japan struggled to recover from the devastation of World War II, husband and wife researchers Otoko and Shosuke Okamoto were making medical history. Working on blood drawn from their own veins, they identified a powerful inhibitor of blood clot breakdown, a process called fibrinolysis. But the full potential of their brainchild, the drug tranexamic acid, or TXA, would not be recognized for decades. First dentists, then surgeons noted the benefits of TXA. A single dose just before incision cut surgical bleeding by a third. But it was half a century later, after the CRASH 2 trial randomized 20,000 bleeding trauma patients to get TXA or placebo, that the world woke up to their discovery. When given soon after injury, TXA cuts bleeding deaths by a third, mostly by reducing deaths on the day of the injury. But the questions remained. Could TXA reduce intracranial bleeding and improve outcomes after traumatic brain injury or TBI? A second global trial was launched. The CRASH 3 trial recruited nearly 13,000 patients with isolated TBI, and again found that TXA treatment within 3 hours of injury cuts deaths on the day of the injury, even in severe TBI. The effect of TXA on early deaths from any cause in the 2 CRASH trials is almost identical, compelling evidence that TXA saves lives after traumatic injury. And there were no adverse effects. TXA is time critical. TXA should be administered as soon as possible, ideally at the scene within an hour of the injury. Urgent treatment of all trauma patients could prevent tens of thousands of premature deaths each year worldwide.
So dramatic. But it's true. It has been proven to save lives. So if you guys have it, give it. Yeah. And now we're on to airways.
Do you give TXA to kids?
I don't think that's in our protocols.
What's that?
TXA to kids?
Uh,
I don't think it is.
no, it's not. Sure, we could call and go that route.
Yeah, I definitely would call early if you have a patient. If you've got a kid who's a trauma.
Well, we've had tonsillectomies that went bad. We would go ahead and nebulize it. So yeah, we've done it.
100%, yeah.
We've already nebulized it.
Yeah, for sure.
That's
Yeah,
awesome.
Yeah, we did. Yeah.
Cool.
Yeah, so we
Yeah.
nebulized TXA.
That's
We've been
awesome.
getting a rash of those here lately. Just blown out tonsillectomies that went bad.
Oh,
Those
I did hear
scare me
about
to
that.
death.
Yeah.
Recently, for some reason.
Horrifying.
Hopefully it's not a problem with the
Those
surgeon.
can go so bad.
Yes, they can. They sure can.
Can you give TXA to pregnant women?
I don't know. Can you?
Yeah, sure can.
No adverse effects.
Nope.
It's a good deal.
I think our first line is toes and posts.
Yeah, I think so.
So when you're making your decisions whether you're going to take somebody's airway or not, questions you need to be asking yourself is, can they protect their own airway? Can they oxygenate? Can they ventilate? And if any of those answers are no, you need to be thinking about doing some sort of intervention. To maximize your interventions, we recommend using the ramped positioning, using a 2 thumbs down technique whenever, which is, you'll see, that's the top picture, whenever you are using the BVM. Put a nasal cannula on at 15 liters for passive ventilation, and if you have adjuncts, use them. They're there. I know that they've been on the ambulances for 1,000 years, so they still work. They still work great. We have supraglottic airways, endotracheal airways, and then surgical airways. Yeah. So you want to hit this one too?
So your end title is reflecting your perfusion status, how well you're ventilating, and also the patient's metabolism. So if you have a patient that's severely acidotic, their end tidal is going to be very, very low. And if it's not very, very low, then they're probably dead or almost dead.
Why is it low instead of high?
CO2 still inside, right?
Nope. So if they are hypoventilating, if they're breathing too slow, you'll see it jump up. But usually when people are super acidic, their body compensates, and part of their compensation is to try and breathe off that acidosis as fast as they can. So you'll see their breathing rate in the 30s for adults and even higher for kids. So that's why it falls.
So it's something to be really mindful of, especially when you've got those like super sick, like sepsis patients. You think that they've got definitely something metabolic going on. If you're gonna have to intubate them, I feel like we always revert to, we're gonna bag them at, 12 to 16 times a minute. But if you have that granny that is like, has a superhuman UTI that you're gonna have to intubate, she's probably breathing like mid-30s before you go to intubate her, and it's really helpful if you put a nasal cannula, an end tidal nasal cannula on them. You're gonna get what their end tidal is, and when you intubate them, you want to keep them at that exact same end tidal. So if you throw an end tidal nasal cannula on them while you're getting them out of the nursing home, getting ready to put them in the truck, gonna have to intubate probably at some point in time, and she's got an end tidal of 25, her body knows how to compensate way better than we could ever compensate for her. So being mindful of that and just keeping note of that after you get her intubated, you're gonna want to keep her end tidal right at that 25 level. Which is kind of counterintuitive because I feel like we're always told like 35 to 45 for our end tidal all the time. But for some of those patients, especially acidotic patients, that's not always appropriate. And then definitely using end tidal if you're coding a patient, because that is going to be like, we are globally really, really terrible at assessing pulse, and I feel like a majority of the time I'm like, I'm feeling my own pulse. Pretty sure I'm feeling my own pulse on this patient's carotid. I don't know whether it's theirs or mine. End tidal is going to give you a much better clue, and you're going to see end tidal jump far before you're going to be able to palpate a pulse on these patients. So if you're, doing CPR and you're hanging out and their end tidal's 15 the entire time, you're like, okay, we're, bagging fine. And then all of a sudden their end tidal jumps to 40, and that's a pretty good clue that you probably have ROSC. And then just a reminder, if you don't have end tidal when you intubate a patient, or even if you go to take a patient, like a transfer somewhere and they're intubated, if you don't have end tidal on them, no waveforms, that number is 0, then your tube is not in the right place. I feel like a lot of times we go to, oh, this is an equipment issue, and we try to troubleshoot equipment and switch our end tidal out about 15 times, when in fact that tube was in their stomach the whole time. And we see that all the time with kids, just because it's a much more hectic situation, way more chaotic. We don't have our ducks in a row as much as we usually do with adults. We're internally panicking, and we need all of those clues to make sure that we have a good AT tube in those patients. So making sure that you have values on your screen. You've got the numbers that correlate, and you've got the waveforms. You've got appropriate rate waveforms. So you should be able to see every time you bag, you have a square waveform, and that goes back down to 0.
Something about kids. Do you guys have ventilators? No?
Yeah, we got small, nothing to talk about too much.
Okay. If you do have ventilators and you do get a pediatric patient, make sure that whatever circuit they are using is for a pediatric patient. Adult circuits are not appropriate. We just had a patient.
Critical care transport. Yeah. I'm not taking that.
Okay,
I mean,
that's fair.
completely valid.
Yeah.
But I mean, how many times have
10 out of 10 times.
me and you taken something that we probably shouldn't have taken by ourselves? Right.
And you shouldn't, because you don't
Right.
have the appropriate size
If you
equipment
no,
for
we
that.
don't have the tubing for it.
Right.
Yeah.
Right. So just something to keep in mind. Make sure that you are using the appropriate size equipment for the littles,
We walk
because
into hospitals all the time, and these kids are on adult vent circuits, small kids, and they are like this close to cardiac arrest because their end tidal is like 150, because there's so much CO2 that's filling up in that vent circuit.
they
And
asphyxiate.
also, you remember our vents, don't you?
It's
Same
yeah,
vents. There's
it's the
stuff
same
you
ones.
can control.
Oh.
Your best guess is 0 to 12.
Yeah.
Somewhere in that range.
Okay.
So, yeah.
That's fair.
And there is no shame in being like, this kid's really sick.
Yeah, call a helicopter.
Yeah, critical care transport is 100% appropriate, because they're trying to send you in the back of an ambulance with one person. Like, we always have 2 people in the back with us, and sometimes we can't even keep our shit together enough with 2 people that, are critically care trained. So them just being like, okay, well, paramedic, you should go forth and prosper with just you in the back to sit there with your thoughts is not the best option. It's just not.
If somebody is pushing you out the door, you need to stop and second guess.
I mean, I've taken them and I said, I want a nurse.
Yeah.
Yeah.
I want an RT.
Yeah.
100%. Yeah.
And we've done that. I've taken critical care. I said, if we're gonna do this, you're coming with me. Well, let me call St. Vincent.
So it's just
And sometimes they just don't even think about it.
Right.
Like, they're just.
they have no
so-
idea.
Yeah,
They have
their
no idea.
brain is spinning, and they're like, "Holy shit, we don't take care of kids. We gotta get this kid out of
Get
here."
this kid
Like,
out of here.
yeah, we're freaking out right now. We don't want to deal with this any longer than we have to. The ambulance said they were 2 minutes away. the helicopter said they were 45 minutes away. Like, I know what we're gonna pick.
Yeah. We had one of the local, not this county, but a different county. The doctor was trying to tell this paramedic that he was going to have to bag a patient that size from a hospital further away than you guys are, all the way to Riley, the whole way. Like, we don't have the correct tubing, so you're going to have to use a BVM. Which is just not, it's just not safe, it's not smart. Set boundaries. Just some pearls to take away with you. Aggressive pre-oxygenation, the closest you can get to 100% before you intubate, the better. Use the ramp position, the ear to the sternal notch. You can kind of see the way that this feller is laying his ear literally is in a perfect line to his sternal notch, and that's going to open up an airway for you a lot better. You can see a lot more. Use the 2-person BVM, 2 thumbs down technique. So I'm holding, my job is the mask and the seal, and that is all that I am doing. And then somebody else works the bag. Use a normal nasal cannula for the passive ventilation. The capnography cannulas they don't have the same amount of flow. So, and then have a plan, have a backup plan, and have a backup to your backup plan, just in case something goes wrong. Because if you mess up an airway, you only got one airway. So you can try the intubation, you can try the supraglottic, and you can try one time for a hole with a cut in the neck. But if those all fail, rip. And then, if you do decide to intubate your patient, give them some analgesia along with their sedation afterwards, and always confirm with capnography.
And if you don't have enough hands to do a 2-person BVM approach, one of the things that we've done, because sometimes we have to intubate in the back of the aircraft and it's not very fun, is taking a BiPAP mask that has a strap on it and strapping it to their face. So it's gonna keep the seal for you, and it's probably gonna honestly do a better job than anybody that's holding it on there, because I feel like we break the seal so many times when we're trying to bag somebody. If you strap that mask to their face, you're watching their airway. So even if they're completely gorged, like that's always something that we talk about, like can't strap a mask onto a BiPAP patient because what if they vomit? You're staring at their face the whole time. So we're keeping an eye on that. So strap that mask to their face if you only have one set of hands to do things with, and get the rest of your stuff ready with, your other hands. And then also for airways, we have a lot of patients, I feel like, that have no chin, usually no teeth, and there's no way that a mask fits on their face at all. If they'll take an eye gel, throw an eye gel down and start ventilating them with an eye gel. There's no harm in that. And a lot of times we'll throw an eye gel down, and if it's working,
We'll leave it.
We're good. We'll transport them just with an eye gel. Unless there's a 100% need for them to, say they're a perm patient or something like that, where you know that you need to have a tube that goes through their vocal cords. If an eye gel's working for you, perfect.
Yeah.
Get them to a hospital and they can intubate them.
Yep.
If you're able to ventilate them, then you're golden.
Yep. Exactly. Babies, little kids, patients, little pediatric airways, they are way different than adult patients. They have ginormous tongues. Their epiglottises are shaped differently and a different color than adults. Their tracheas are much shorter than adults. And angles are way different as well. So your pediatric patients are going to be a little bit more anterior than an adult patient. The narrowest point is also different. So the lowest point of the epiglottis is more narrow than the top, than it is opposite for adults. And then lung volume is way different for peds than it is as adults as well. We always kind of say 6 to 8 mils per kilo of ideal body weight, whenever you're choosing how much volume to ventilate your patients with. Use a shoulder roll. Positioning is important for little kids too, just because of how they are built. And then just some other special populations and considerations to keep with them. So geriatric patients, their population is growing. I don't remember the exact number, but it's way higher now than it was 20 years ago, and that's just because we're coming farther in medicine and treatments. So some
Artificially preserving people.
yes, literally. Some challenges to just keep in mind whenever you're dealing with the geriatric patients. A lot of them are on a million different medications, and they probably don't have a clue what they are. So the more information you can get, the better treatment. A lot of them are on anticoagulants, so they're going to bleed a lot easier. They're just frail in general. They break easier, and their hearts are usually well worn. So just keep an eye on fluid overload and silent shock. Another thing to keep in mind as far as the silent shock is concerned and the polypharmacy, beta blockers are going to be a mask for shock. Because you may look at this patient and be like, this person looks like crap, but like their heart rate is 58. And you're like, why? Well, then you look at their med list or you start pulling out their bottles and you're like, oh, okay, this guy's on like 6 beta blockers. That has something to do with that. Pregnancy considerations. So they have different oxygen demands than we do. And they also have lower blood pressures normally than non-pregnant patients. So just keep that in mind whenever you're treating your moms. Hemorrhage control is a big deal. Remember, you're going to save mom first. The better situation that you can get mom into, the better situation the fetus is going to be in. Don't lay them supine. When possible, use the left displacement. CHF and kidney disease patients. Too much fluid is going to cause worse outcomes for them. They are more prone to pulmonary edema and respiratory failure. So use your smaller boluses and then just reassess them frequently. TBI patients, you're going to see these patients and their blood pressures are going to be ridiculously high, and you're going to want to treat that. But they need it a lot of the time. So permissive hypertension is a big thing with these people. Avoid hypotension at all costs and keep them super warm, because if they do end up with any sort of hypotension, that reduces their survivability a lot.
A lot of times neurology tells us, because like we'll see if they have any orders for patients that we're transferring that have traumatic brain injuries, and a lot of times they don't want their blood pressure to get below like 140 to 160.
Yeah. Okay, so let's do some case review. So you've got a 25-year-old who was involved in a motor vehicle rollover. They were ejected whenever you arrive on scene. They're unresponsive, heart rate's 130, respirations are 33 and shallow. What's your treatment?
Obviously, it's a trauma alert. Being injected. Assess the patient. You see he's unresponsive. We're in control of the airway. Do a quick assessment and see if he's bleeding anywhere. Can you see anything?
Nope, you don't see any bleeding.
Okay. None at all?
You don't see, I mean, some bruises and some abrasions, but other than that, you don't see much bleeding on the outside.
Okay. Do people ever respond?
They're sluggish and about a 3.
Are they equal?
Yeah. Anybody else want to jump in? Sluggish.
Get the billing information.
Get the billing information. They don't have insurance. They don't even have car insurance.
Liability only.
Yeah.
Obviously, it's hypertensive, tachycardic. They're bleeding somewhere.
Yep.
Yeah.
So if you had blood in this case, Would you start blood immediately on him?
I would work with some fluid first and then go blood second. Maybe, no, just straight blood?
I would go straight to blood.
Blood.
Okay.
Yeah. They have the mechanism there, and
That's part of the mindset that we always think about, because we've all been trained to do that, but little stuff first, then we get to the bigger stuff, it seems like over the years, so.
Yep.
If that's the case, that'd be great.
think the opposite with trauma patients. You want to just go for the blood.
Full send.
Go for the blood and treat with fluids later on if you need to. Yeah.
A lot of times if we have trauma patients, because we carry 2 units of whole blood usually, if we don't use it before we get to the next patient, you would be really, really surprised with 1 unit of whole blood how much it changes the patient's hemodynamics. Like, it improves their blood pressure so much better than a liter of fluid, and it's half the volume. I mean, a whole blood unit is only 500 mils, but once they get done with that unit of whole blood, a lot of times we can get their blood pressure to hold, and they'll be good for the rest of the transport, and we won't even give them any fluids.
What's your rate?
As fast as we can.
bag.
Pressure bag. Yep. Fast as we can get it in there. Yep.
Show them
Do you guys carry pelvic binders?
We do.
Yeah. That's another thing to keep in mind whenever you have trauma patients with mechanisms sort of like this. You've got trauma season right there. You can bleed out a lot in your pelvis. So if you can get pelvic binders on quick, that's going to help their outcome some too. All right, you got an 11-year-old ATV crash. They were helmeted. They were wearing shorts and Croc shoes while they were riding. Your heart rate's 145, blood pressure is 110/68, respirations are 30, skin is pale, multiple contusions, complaining of stomach pain. You see some redness and bruising noted on the hips and lower abdomen. What are you gonna do?
She's fine. She's fine.
So, she's fine.
He's complaining, so we got that going for us.
Yeah, he's awake. That's good.
He's got a hot belly.
He's got a hot belly. What are you gonna do to treat this kid?
Blood.
Blood, what else?
TXA.
Yep, what else?
Do you want to give blood even though his blood pressure's 110/68?
It could be compensated. Hypotension, pediatrics is only crime.
For sure. If he looks like
Yeah.
that,
Yeah.
give the blood.
Yep.
You're screwed.
Yep.
Yeah.
Yep. Good job, guys.
So
Oop.
that is something that your protocol will probably state, because they have to, is they have to give parameters for when to give things. But another thing that is really great about a paramedic is that we can, it is our job to explain what we see on the scene and to give good reasons as to why we do things. So if I see a kid that looks like this, technically our protocol is that they need to be hypotensive in order to give blood. But it also does say, or if they're showing signs of shock. So they've got a normal blood pressure, but he's pale, and you know for almost certainty that he has bleeding in his belly and his pelvis. Like, I'm gonna say that the patient looked awful.
And the heart rate. Your heart rate is the clue here, because he's 11. How high is a normal heart rate for an 11-year-old? On the high end.
160, 170?
For an 11-year-old?
I don't know.
No, like
Pretty close to it.
I have my card.
90 is maybe on the highest side. What?
100,
220
110
minus
maybe.
11?
Yeah.
209?
Yeah. So 145, that's way high. So they are working their way towards that drain. So, yeah, good job, guys.
Another thing is that his shock index, which I don't know if that's a term that you guys have heard before, shock index. His heart rate is greater than his systolic blood pressure.
Mhm.
Yeah.
So if you have that, then that means that they're definitely showing signs of shock. So that's another tool that you can use in your charting to be able to explain as to why you're giving that patient
Shock index greater than 1.
Shock index greater than 1, and his shock index is much higher than 1.
Okay. Next one. We got a 78-year-old female, strong odor of urine in the room. She's confused, febrile, hypotensive, 84/54. What's going to be your treatment for this lady? Fluids, how much?
LR, a liter, and then start pressors if it doesn't improve.
How much fluids are you going to start with?
A liter, 50 ml.
Yeah, but like
Well, I don't know.
30 per kilo. Yep. Okay. So we're changing. We are growing. That's the way that medicine goes. It always changes. So we ask, like, are things appropriate to treat with fluid, or do they need blood? Do they need help with clot preservation? Does the patient need hemorrhage control? Do we need to put a tourniquet on? Do we need to pack a wound? Does this patient need help with their airway, or are they good to keep doing what they're doing on their own? Do they need help with perfusion? Resuscitation is no longer about filling a tank. It's about restoring oxygen to tissues. Questions? Comments? Concerns? Donuts?